Hi everyone. We are so happy today to congratulate our authors with Editor's Choice article of Journal of Cephalalgia. Dr. Sacco dedicated this amazing article. And please, if you could introduce yourself and tell us a little bit about you, where you are tuning in from.
Mhm. Okay, well, I'll begin. My name is Peter Drummond. I'm a professor of psychology at Murdoch University in Perth, Western Australia. Just a little bit about myself and my background, how I became interested in migraine and also in complex regional pain syndrome, what we call CRPS. So I first studied mechanisms of migraine and other types of headache during and after my PhD in the early 1980s with Professor James Lance in Sydney, a famous neurologist, very well known in headache circles. When I moved to Perth in the late 1980s, I was keen to clarify mechanisms that might underlie autonomic disturbances in trigeminal autonomic cephalgias, such as cluster headache. So I was introduced to my friend and collaborator, Dr. Phil Finch, who at that time administered stellate ganglion blocks to treat the pain of CRPS. This procedure inhibited sweating and also skin blood flow, not only in the painful limb, but also on that side of the face. The similarity and possible common source of autonomic disturbances in cluster headache and CRPS triggered my interest in mechanisms of CRPS and, in fact, mechanisms that might be common to both types of conditions. So over to Phil.
Well, thank you, Nina. It's really nice to talk on this. I'm an anaesthetist originally, and I was introduced to Peter Drummond 35 years ago, and we've had a wonderful collaboration working in this field. And at the time that I met Peter, I was performing sympathetic blocks called stellate ganglion blocks for treatment of complex regional pain syndrome, CRPS. And Peter found this, heard that I was doing this, and hence the collaboration. And we noticed in work on this topic that there was a high preponderance of hemisensory changes, sensory changes right down one side of the body. And so we have been studying that since. And Peter, would you like to talk about previous studies?
All right. So what really initiated this particular study was that it was already demonstrated that migraine is a risk factor for CRPS. And this suggests that similar mechanisms may be involved in both conditions. So having one of these conditions might worsen the other. So this is what we set out to explore.
So, Nina, I, as a clinician, pain clinician, saw a wide spectrum of pain, chronic pain patients, and some of them had this intriguing condition, complex regional pain, which had a very obvious autonomic background to it. And so I referred them to Peter here at Murdoch University, and he studied them in a laboratory with careful sensory findings. And I think you could probably talk also a structured interview, especially an interview regarding their past headache patterns. And so, Peter, would you like to talk about that?
Okay. So in terms of the patient's headache story, I was interested to find out whether the headaches had changed after the CRPS started. We already knew that having headaches beforehand might increase the likelihood of CRPS. But then what happened after the CRPS developed? Did the headaches stay the same? Did the headaches go away? Did the headaches get worse? We didn't really know. So we administered a fairly standard headache interview based on the criteria for migraine headache and tension type headaches. In our series, we didn't have patients with other types of headaches. People with trigeminal autonomic cephalalgias were fairly unusual. We have actually published previously on 2 patients with comorbid CRPS and trigeminal autonomic cephalalgias, but they weren't included in this particular study. The focus was on migraine and tension type headaches. So the headache interview was to establish whether patients met the international criteria for those 2 headache disorders. We also studied the symptoms of CRPS in a standard way. This involved doing psychophysical tests, sensitivity to pressure, to light touch, to heat, to cold, and to lightly brushing the skin. All tests designed to work out whether there was some difference or abnormality in the person's sensitivity to these very common types of stimuli.
That's a very interesting methodology. So would you start with participants who had this CRPS and headache, or would you start with participants who has a person with CRPS and you would ask, do you have headache? How did you enroll?
We enrolled everyone who had CRPS, irrespective of whether they had headache or not. So people who didn't have headache were particularly interesting and important to include in our study so that we could find out what protected them against the development of headache. The tests that we did during the assessment process also involved mapping out which parts of the body were affected by CRPS, whether it was an upper limb or a lower limb, and how much of the limb was affected by pain, how intense the pain was. We simply asked people to give us a rating between 0 and 10 for how severe the pain had been over the past week. And another focus of our study was to assess sensitivity to light. We'd found previously in one of our studies that people with CRPS had what we call photophobia or heightened sensitivity to light. And so we measured the visual discomfort threshold, both for the eye on the painful side, on the CRPS side, and also contralaterally.
What did you find out in results?
Okay. Well, we ended up studying 88 people with CRPS. About 2/3 of our sample were women. Most were middle-aged. And CRPS had been present for at least 1 year before we assessed them. Most took medication for CRPS, and this is an important thing to note because medication potentially could have influenced our findings. Only about 1 in 4 or a quarter of our patients recalled having regular headaches before the injury that triggered CRPS. However, when we assessed them months or years later, around 85% of patients reported regular headaches that usually resembled either migraine or chronic daily headache. So no patient actually reported that the headaches had diminished or disappeared altogether after the CRPS started. So in general, headaches got worse after the onset of CRPS.
Were there any differences if people were younger, participants were younger versus like older adults?
Well, the younger people seem to be at heightened risk for developing migraine after the injury that triggered CRPS. And this was interesting in that migraine prevalence peaks in the younger years, in young adulthood, and diminishes thereafter. And so there seemed to be a heightened risk not only for developing CRPS in people with migraine, but that the younger people were more susceptible to developing both conditions together.
Yeah, that's amazing findings. And we really appreciate this publication. Why do you think you observe this link? What the hypothesis? I know your articles outline few potential mechanisms.
Yeah. Well, just to fill in a few more of our findings, which could be important in terms of trying to understand mechanisms that might be responsible. We found that it's a paper. We found that in most cases, the headaches were exclusively ipsilateral to CRPS or affected both sides of the head. So there seemed to be some link there between the site of CRPS and where the headache actually developed. So there might be some sort of anatomical link there that is giving us some clues about what might be going on. There were only a few people who developed headaches which were contralateral to CRPS, and we don't fully understand why the headache developed there in those people, but perhaps one explanation might be that people with complex regional pain syndrome describe a spreading of their pain. It doesn't simply stay in the injured area. It starts to spread to involve other parts of the injured limb and sometimes other parts of the body. Sometimes this pain actually spreads contralaterally, and it might be that this process which drives the spread of pain resulted in the development of contralateral rather than ipsilateral headache. But by and large, the headaches developed most forcefully on the injured side, on the CRPS affected side. So that's an important thing to consider. The headaches were more likely to have a migrainous flavour than a tension-type headache. And the symptoms, the cranial symptoms associated with migraine, such as scalp tenderness or hyperalgesia and of photophobia, were stronger in people with migraine than in tension-type headache, as you might have actually anticipated, and were more lateralized in people with migraine than in tension-type headaches. So that's another important thing to keep in mind when trying to understand what might be happening to cause this crossover or this link between migraine and CRPS. In a small proportion of our cases, the pain of CRPS actually spread to involve the whole forequarter. And this involved not only the limb, but also the back of the neck. Now, this might be an important mechanism of pain or an important source of pain, particularly of headache, because pain can be referred from the occipital area through to the trigeminally distributed parts of the face. However, this couldn't be the only explanation for pain. For this connection between CRPS pain and headache pain, because we also saw the development of ipsilateral headache in people with lower limb CRPS. So there, the referral mechanism would seem to be unlikely. So I'll just pass back to Phil now for a brief overview of what
I think Peter said it all. But just sort of summarising, our findings suggest that migraine and chronic daily headache tend to develop or worsen after CRPS begins, and the two conditions seem to be related, and it suggested that there may be common mechanisms involved, especially, and Peter mentioned that younger patients seem to get the more severe CRPS, and they also had the more severe migraine headaches. And we thought that the background to this must be central sensitization and a loss of inhibitory pain controls. So we found that actually headaches and cranial symptoms were stronger on the side that had the CRPS. So the two seem to go together, the two conditions, and that's what intrigued us. Peter.
Okay, so like always, more work needs to be done to clarify the link between CRPS and headaches. In our previous work, we found an upregulation of alpha-1 excitatory alpha-1 adrenoceptors on nerves in the affected limb, nerve fibers in the affected limb. And it might be that the upregulation not only involves the peripheral part of the nerve, but also the part that projects into the spinal cord. If so, this might then alter the balance between inhibitory and excitatory processes that control the flow of nociceptive messages through the spinal cord through to the brain. If the balance moves towards an excitatory end, noradrenaline released during inhibitory pain control mechanisms within the spinal cord might paradoxically increase nociceptive signaling rather than decrease nociceptive signaling. And we speculate that this imbalance, this balance more towards an excitatory rather than an inhibitory process, might then result in the development later on of headache, particularly ipsilateral headache, and ipsilateral cranial symptoms such as photophobia and scalp tenderness.
Excellent. And of course, you mentioned something in the beginning, preceding it as doing stellate ganglion block. I know that many headache and pain centers looking into these procedures all around the world. Do you envision that we have more answers from your future research on that, or how do you feel about the effects of this procedure on improvement for this group?
More questions than answers.
More questions for research, right?
So I was just going to say that I was going to just talk about briefly before we conclude, Nina, that other mechanisms may be involved than CRPS, obviously, in the development of migraine headaches. Our patients are very chronic pain patients often have mental health issues and are psychologically quite stressed. And this does have neurophysiological correlates in the spinal cord. Isn't that true, Peter? And the other thing, Nina, is that medication overuse may be a problem causing chronic daily headaches. We're always trying to reduce medication use in chronic pain, but it can be quite difficult, especially if they get started on opioid drugs.
Those are excellent points. Were many participants on opioids within the study?
Only a small proportion were on opioids, but it's possible that there was some sort of addictive process with some of the other pain medications that might have influenced the development of headaches.
Yeah, it's super exciting, and it's not only opens window into this amazing combination of two, but also creates more road for future research. So thank you so much, and we really appreciate and congratulate this article, Editor's Choice, which published in the Journal of Cephalalgia. We hope that our viewers and listeners will look into more detail in this publication, and we really hope to see you again soon with more publications and research, which all headache community really needs. Thank you so much.
Very much hope so, yes. We're looking forward to working in this area this year.
Thank you, Nina.
Thank you, Nina.
And thank
you. It's been a pleasure talking to you.
And thank you again for interviewing us about our research, and also we both feel very honoured to have received this opportunity.